Hi, my name's Jonathan and I'm the simulation facilitator here at Rotherham Hospital. Often get called the sim guy. Simulation is a way of learning that's used more and more in healthcare. It's been used in a lot of other high risk industries. Everyone will be familiar with flight simulators for the aviation industry, but other high risk industries also use a lot of simulation. Well, healthcare is the highest risk industry around, so it's only right that we recognise that and that we use simulation to help people learn and develop their skills at managing particular incidents and particular scenarios. We can teach a lot of things in a classroom or reading books, but we really don't know whether we can actually implement those things, whether we can actually carry out those tasks until we try and do it in practice. And it's really not the best thing to be practicing very dangerous or high risk things for real in the first instance. So really we want to be practicing those things in simulation. So we get an opportunity to practice certain scenarios, practice certain events in a safe environment, and then we can reflect on that and we can think about how we did that and develop strategies for dealing with that same scenario should we ever encounter it again. The way we usually carry out simulation is, first of all, we will run a scenario after we've introduced people to the equipment and the mannequin. We'll run a scenario. Now we can either run that scenario here in our simulation area, or we can actually take our equipment onto the wards and run it in the real clinical areas, which is by far and away the best thing to do. That's the gold standard. By doing it in a clinical area, we're using the right team with their own equipment. We're not asking them to artificially look for things that they wouldn't have any difficulty finding normally. So that's a really good way of doing simulation, but we can do it. Clinical areas are busy, so we can do it here in our simulation area should we need to. So we'll run the scenario, and we're looking really for a number of things when we run those scenarios. So as I said, we want to see whether people can recall the knowledge and the skills they might need to have, but we also want to look at their interactions with a team, whether they can work well together as a team, whether they can communicate. These human factors, we call them, where we're looking at the way a team behaves and the way individuals within that team actually behave, and they can be really important. Like I said, we can learn stuff from a book, but whether we can implement those things and do those things is another question completely. So we'll look at those scenarios, and it's very important that simulation is a safe area. So if things go wrong in that scenario and things perhaps don't go as they should, that's not a bad thing. That's a good thing, because it means it went wrong in simulation, and people can come away and they can reflect on those things, and should they then encounter that same scenario in the real world, they've already had some experience of having to handle that scenario before they've encountered it for real, and that's very important. Simulation is not about teaching. Often people think that there's a teaching element to simulation, and actually I would very much argue that's not the case. By the time you arrive in simulation, you should already have the skills and the knowledge that you need to handle that situation, and if you don't, simulation isn't the place to teach you those things. Simulation is the place to identify those gaps in knowledge, and then we'll go away and we'll teach them separately. So that's all very important. Once the scenario is complete, we'll then go on to conduct a debrief, and this means getting everyone together and getting them to sit down, the team that was involved, and often observers as well, because we'll often have people who've observed the scenario but not necessarily taken part. And we'll sit down, we'll have a reflective discussion about that. So what we mean about that is we have a very structured way of talking about what happened in that scenario, what people experienced, what their thoughts were on what they did and what they didn't do, and kind of looking at the way people structure their thought processes during that scenario. And we'll explore that, and we'll do that in a very non-judgmental way. The observers, so often we have a lot of people attend a simulation course. Certainly prior to COVID that was the case. So we could have 12 people attend a course, maybe more. All of them couldn't take part in every scenario, so what we'd do is we'd have a more realistic sized team of say 3 people take part, and everyone else would observe. And those observers are really important, because often the things that you perceive to be happening while you're in a scenario are completely different to the things that you would observe if you're stood dispassionately back observing that scenario, like it was watching an episode of Holby City or something like that. And often people are very unaware of their behaviours and their actions whilst they're taking part in a scenario. It's very kind of distracting, and you know, it's very difficult to understand what your actions were at the time. So having dispassionate observers who observe those actions from outside is really important, and they have a lot to contribute to the debrief. And that's it. Then after we've had the debrief, we'll usually ask people to have a think about how that scenario would affect their practice and what they may have picked up from that to change their practice, or to reinforce those good practices that they had, or change things that might not have been as good as they were hoping. So if you guys do go on to have careers in medicine, one thing I can guarantee to you is that you will be doing more and more sim. Sim is really growing as a method of learning and developing reflective practice. So doctors, nurses, all healthcare professionals are expected to do far more sim. So it is definitely on the increase. So you'll be working with our mannequins before long. So our main workhorse here in the simulation suite is Metiman here, also known as Richard. He's what we call a high fidelity patient simulator. We know he's a big plastic doll, he's a mannequin, but packed inside here he's got lots and lots of high technology features that allow us to mimic most conditions that we'd expect to see in a patient. The first thing is we have a monitor here that we can display any observations we want, and we can make this more complex. We can make this look like an intensive care monitor, or we can do other things to it. We can make it more basic depending on where we're working and where we're simulating. Richard here, he can do quite a lot of things. So you can hear that he's breathing. We can listen for that when we're assessing him. We can also watch his chest rise and fall, just as we would with a real patient. He blinks, and if he's rendered unconscious, his eyes will shut, and you will be able to, you know, he won't be opening his own eyes. We can make him respond to voice or pain or anything else that we would expect on a real patient. His eyes react to light just like a real human's would, so we can shine a torch in there and we can watch his eyes react. He has a completely functioning airway, so we can do any emergency procedures that we would do there. So we can suction that, or we can put in special airways to help him maintain his airway and help him stay alive. We can do more complex things on there, and he has a lot of features where we can make it more difficult depending on the skills of the participants. We can attach him to all our normal equipment that we would use, or a lot of our normal equipment that we would use in hospital. So it can be attached to a defibrillator, just as a real patient would, and he can be attached to a pacing machine, just as a real patient would. He has heart sounds and breath sounds, so people can listen with a stethoscope and listen for any unusual sounds. And he also has pulses everywhere you would expect on a real patient. So we can find pulses in the wrist, or we can find pulses in the upper arm, we can find the pulse in the groin, and pulses in the feet. He also has a tank a fluid tank on board, and we can actually fill him up with fake blood, so we can actually make him a trauma patient. We can make him bleed from anywhere we want. We do that by concealing a little plastic tube to wherever the injury that we want to mimic is. He's a very nice piece of technology. He can talk, he has a number of pre-recorded sounds, but he also has a speaker inside that, using a remote microphone, we can respond and we can answer questions just as a real patient would. So the beauty of using a mannequin like this, rather than the more basic kind of things you may have seen in the past for basic life support and things like that, is we can use this mannequin while we're in the control room. So we don't have to be here feeding the participants information. We can let them get on, we can let them manage this patient as they would normally. So the matriarch of our little family of mannequins we have here in the Sim suite is Sim Mum here. So Sim Mum's not quite as advanced as our other two mannequins that we use, but she does have the unique feature of being able to have a baby. So she has a device that we fit inside her belly, and without someone being here, we can make this the mannequin deliver this baby. This allows us to train anyone who might be put in the position of having to deliver a baby in an emergency. So that might be the midwives, the obstetricians, but it might also be other people like paramedics or people who work in A&E, where they get unexpected pregnant ladies arrive and they have to manage these situations urgently. So this baby here can be delivered from this mannequin. All the other features, she can have all the other features that a pregnant lady has. We can attach her to the normal equipment that you would use on a maternity ward. So one of the things we do is we can attach devices to listen to the baby's heart rate while it's still in the uterus, and all of that will work with little speakers in here that will pick up the sounds of the baby while they're in there. All the observations that they will see can be displayed on this monitor here, and again we can change those to reflect what conditions we want to represent from the patient. It's really important that we train people to deal with maternity emergencies. Maternity emergencies account for, by far and away, for more compensation payouts for the NHS than all other things combined. So if you add up everything else, it still doesn't come to a fraction of what we have to pay out for maternity emergencies. When things go wrong with maternal emergencies, we haven't got one patient, we've actually got two, and that is why those payouts end up being so much more sizable than all other things combined. So we do a lot of training for obstetric emergencies. So Sim Baby here is one of our newer additions to the family. Sim Baby has a lot of technical features that allow us to mimic how poorly a paediatric patient might be. First of all, we can make Sim Baby have various sounds, from crying, or we can make it content, so happy giggly baby. We have a variety of other sounds we can play as well, depending on what we want to, what impression we want to give about the baby. The mannequin also has heart and breath sounds, which with a stethoscope you can listen to the chest and you can listen to the heart and you can hear different sounds, and we can tweak that depending again on what we want people to hear. Other features we have is in particularly young children, we can do we can affect what we call the fontanelle. So with particularly small babies, the skull bones don't close up until they're 6 months old or so. So we can make that area of the skull bulge, which is something that can get in particularly serious conditions. You'll see the mannequin, it also blinks, so its eyes are opening and closing. We can make it close its eyes, we can speed that blink up, or we can slow it down. One of the other things we can do is by shining a torch into its eyes, we can demonstrate that its pupils are reacting. again just like you would with a real baby. It has nostrils and it has a mouth, and inside of there is a functioning airway, so we can do everything we would do to help a baby of this age breathe, including putting a tube down there, and there are various options we can use to make that more difficult or less difficult depending on who our participants are. The mannequin also has a couple of points on the chest where we can do particular interventions. So this is to drain something called a tension pneumothorax, which is when air gets trapped between the heart and the chest wall, the lung and the chest wall, and it can squeeze the heart and cause a lot of problems. And the port here on the side, we can put chest drains in, which you do when you have a collapsed lung. You'll be able to notice, if you look carefully, you can see the baby's belly rising and falling as it breathes. Now, a lot of young paediatric patients of this kind of age tend to do what's called belly breathing. So you see their belly move more than you see their chest move. So we can watch for that. So people can count the respiratory rate, and we can tweak that as we need to. The mannequin also has pulses that we can feel. So with babies, we tend to feel a pulse here in the upper arm called a brachial pulse. That's because the pulses in the wrist tend to be too difficult to find and too weak to find. So we tend to focus on these brachial pulses. Another feature of this mannequin, which I particularly love, is something called the capillary refill. Now, one of the things we do when we're assessing a patient is we press on a central part of the skin, such as the chest, to squeeze the blood out, and then out of the skin, and then as we take the finger off, we can watch the blood get back into that area. So we press it till it goes white on a human, and then we'd let go and we'd watch that white area begin to get pink again. On this particular mannequin, it lights up, so when we press the button in there, it lights up and we can watch the light fade, and that light should fade over 2 seconds if there's nothing to worry about. Anything more than that, and that's a sign that we might have a problem. All the observations are displayed upon the screen here, so people can see what observations they need. This is a fake monitor, but all the information that we get with a real monitor can be displayed there, and they can do things like checking the blood pressure. So you see the blood pressure's changing there. All of the features of this mannequin are controlled by this handheld tablet. So by using this tablet, we can tweak everything, we can change it, and we can make different things happen. The mannequin and the tablet are completely wireless, so we're able to walk around with this mannequin just like it's a real baby, which means we can walk into a place like A&E with a mum holding the baby or a father holding the baby, which all adds to that sense of realism and urgency that you get in the real world. So here now we have the control room. When I think of this room, I like to think of the Wizard of Oz and the way he hides behind the curtain, pulling the levers and creating the illusion for Dorothy and her companions, and that's very much what we try and do in this room. From this room, we're able to observe everything that happens next door, and we do this through a one-way mirror, so the participants the other side of that window can't see in, but we can see everything they're doing. We can also watch 2 monitors here, which allow us to get different angles, so we can try and catch everything that's going on. The participants in the room, if they need help, they're able to phone through a normal work phone, and they're able to call any number that they would normally in the hospital, but instead of it going directly to the hospital switchboard, it comes through to this room. So we're able to pretend to be whoever they're asking for help from. So we can be a specialist doctor, we can be switchboard, we can be whoever they need to be, and that allows us to feed information that might be essential for them in that room. We also could control the mannequins through here. We have computers which connect to the mannequins, so when the mannequins are on, we can alter their physiology from in this room without us having to go there. And altogether what that does is it allows us to create an illusion of people being able to manage this patient themselves, and not to have an instructor stood over them feeding them information, which is how a lot of stuff's been done traditionally. So I love being in this room, I love controlling the mannequin, and I love watching the participants' reactions to what we can throw their way. So I hope that's given you some insight into what SIM is all about. I hope it's been informative. I'm sorry we couldn't meet you all in person. It would have been fantastic to be able to do some things with you. Unfortunately that wasn't to be the case, but I would just like to say thank you for watching, and I wish you all the best for the future.